Okay. Good evening, friends. Thanks for joining us tonight. You've never been with us before. My name is Megan Remington. I'm our community education coordinator here at Coconino Community College. And we have had a slew of awesome lectures over the past handful of months. And tonight's is no exception. I've gotten a lot of enthusiastic comments about this particular topic about diet and gut health and all of the crazy details that come along with that. And so we are so fortunate to have Dr. Andrea Hubbard join us and give us a really fun presentation from her location in Kanab. So she's not too terribly far from Paige. And we're so happy to have her offer up her time to present to us tonight. Andrea, you are welcome to introduce yourself and take it from here.
Okay, thank you so much, Megan. So you can see from my title here that I used to be a professor at the University of Connecticut, the School of Pharmacy, and I've since retired to Kanab about a year ago. And if any of you would like to reach me or reach out to me, there is my Gmail address. I'm actually going to stop my video so that it is not quite so distracting. So I want to thank you so much for inviting me to the Comet talk on You Are What You Eat. And as you look at these objectives, what I want to emphasize and what I hope you'll get from this presentation is really the exquisite communication between the bacteria in your GI tract and the immune system in your GI tract. And the bottom line being diet can affect that bacteria or microbiome, which can affect the immune system, which can increase or decrease our risk of diseases. So here's an outline of what we're going to cover over the next hour. And what you'll see this slide interspersed periodically in this talk. And what I do is I highlight what I'm about to cover in red. So what we're going to see first is a very brief overview of systemic immunity. So as a reminder, the immune system is divided into two arms or branches. The first is innate. And as you can see here, this occurs within a few hours after infection. And there are elements that really don't change based upon the kind of infection we're faced. It can be things like tears or stomach acid, saliva, mucus in your lungs or GI tract, even nose hairs or oil glands in the skin. It can also be epithelial barriers and a type of cell known as phagocytes, which engulf and destroy pathogens. Now, if the innate immune system doesn't take care of the pathogen, we then move on to adaptive. And this is really the key of protection. And this relies upon two different kinds of cells, B lymphocytes, we also call these B cells, and T lymphocytes, or T cells. And in the case of these cells, it really depends upon proliferation and differentiation. So B cells divide and differentiate to eventually make antibodies. T cells also divide and differentiate to become different subpopulations of effector T cells. And you can see that really the gearing up of this adaptive immune response takes several days. What you'll see here again is dividing this into innate immunity, and you'll see some cells that are representative of innate immunity, macrophages, again, phagocytic cells, granulocytes. What's important on this slide is, again, the B cells eventually making antibodies, and these T cells differentiating into different functional subpopulations. Some are called T helper. So whenever you see the designation TH, that stands for T helper. 1, 2, 17 are some of the cells we're going to talk about tonight. There's also a group known as T regulatory cells. Now, T helpers and T regulatory cells have on their surface a protein known as CD4. And I think immunologists name some of these cell types for job security because you look at the T helper, that makes sense, but the different numbers behind them don't tell us what they do, what their targets are, where they come from. So this, unfortunately, you're just going to have to memorize. The ones we'll focus on tonight are going to be TH1s, TH17s, and T regulatories. Oftentimes we abbreviate T regulatories as Tregs. We also have a group of T cells that have on their surface a protein known as CD8. And these tend to be cytotoxic T cells. And to give you a little idea of their role in perhaps a viral infection, B cells and antibodies would prevent the virus from attaching to the target cell, such as an epithelial cell. Whereas once that epithelial cell is infected, it's these cytotoxic T cells that will kill the infected cell. So how do these two arms fit together, innate and adaptive? Well, we certainly see here is the entry of our pathogen. In blue is our innate immune response. Again, if that does not eliminate the pathogen, we then go into the adaptive with lymphocytes. And you can see here the real buildup, the proliferation, differentiation of these lymphocytes. This is where we're going to see a lot of T helpers and cytotoxic T lymphocytes. Once we have cleared that infection, the immune system comes back down to balance or homeostasis. So there is suppression or death of these effector lymphocytes. And this is where T regulatory cells come in. They help to quell or bring that immune response back down to baseline. Now, one of the other aspects of this adaptive immune response is the generation of what we call immune memory, so that the second or third or fourth time we see that identical pathogen, we mount an immune response that occurs earlier, goes higher, and lasts longer. And of course, this is the basis of vaccines. Consider vaccine the first time you're exposed to a pathogen. So when you see that pathogen in a true infection, you respond much quicker and can eliminate that infection for a longer period of time. We're going from the systemic, from the whole body immunity to the gastrointestinal tract. And it too has aspects of innate immunity and adaptive immunity. So innate, I've colored in blue text, whereas adaptive in red. So in the stomach, there's things like the acid pH. In the small and large intestine, certainly the normal bacteria or normal microflora can compete away pathogens. There's movements of the contents of the GI tract. There certainly is mucus and bile acids, and there's shedding and replacement of the epithelium lining the GI tract. In the small intestine, we also have an aspect of adaptive immunity with an antibody known as IgA. This is selectively found in mucosa, the lining, as well as in secretions. So we would find IgA in tears as well as in saliva. There's also lymphocytes, both the T helper 1, T helper 17, and the Tregs, and then the place where the lymphocytes tend to reside, which is lymphoid tissue. So that the digestive tract really begins with the mouth and the esophagus, the stomach, moving into the small intestine, which can be defined as the duodenum, the jejunum, the ileum, and finally the large intestine or the colon. Now let's take that GI tract and kind of isolate it from the rest of the body. And again, you'll see those terms I just used to describe the small intestine as it moves into the large intestine. And you can see here that the different elements of food that are in the small intestine, as well as microbes, and in the large intestine, really a great diversity and number of normal microbes in the large intestine. Now, if we cut the large intestine in half here, this is what we would see. So in the middle is where is the lumen, and that's where the bacteria reside. That is surrounded by villi as you can see here, and there's a layer of mucus that overlays that villi. Now, once again, if we were going to take this section of GI tract and cut it and flip it on its side, this is the picture we would have at this point. So if you'll follow here, we're looking at the small intestine, large. So here's the lumen with all the bacteria. Here is our layer of mucus in green. And then here are the villi made up of enterocytes. And on top of them are what's known as microvilli. As we look at elements of the small intestine, we see there are Paneth cells, which make what's known as antimicrobial mediators. There's also goblet cells, pictured here in green. They make mucus. There are enteroendocrine cells, which can secrete hormone-like substances. And as we described, these enterocytes, which form a nice tight barrier and prevent any bacteria from the lumen from moving into that underlying tissue. Now, within the large intestine, again, there's lumen, and you notice there's a lot more and a greater diversity of bacteria here. There's also two layers of mucus, an outer layer and an inner layer. It too makes antimicrobial proteins, goblet cells to make mucus, the enteroendocrine cells, and finally in the large intestine, its barrier is colonocytes. And you'll kind of notice that the villi in the large intestine are shorter and wider than those in the small intestine. So let's look at some other players, especially the immune cells in the GI tract. Once again, we see these Paneth cells making antimicrobial proteins. We see goblet cells, which are making the mucus, kind of pictured here in orange. We also see in this underlying tissue, we start to see the immune cells. So here we see T regulatory cells. Remember, they are anti-inflammatory. We see Th17s and Th1s. The thing to remember about those, they are pro-inflammatory. So should we get an infection, we count on Th1s and Th17s to protect us. Once that infection has been cleared, we rely on Tregs to then bring the immune response back down to baseline. Now we also have B cells, which can make that IgA, that antibody found in secretions. And the IgA also moves into the mucus layer as well as into the lumen. So again, what we're looking for, and this will come up time and time again, we're really looking for balance in the immune response of the gut, the balance between pro-inflammation and anti-inflammation. So we've defined the immune response in the GI tract. How about the gut microbiome? Well, certainly there are something like 100 trillion bacteria in the GI tract, with the majority in the large intestine. Colonization of the GI tract begins at birth. And the microbiome, the normal microbiome, has evolved with us to become commensal, where if you think about partners, microbiome and the host being a partner, with commensal, one partner benefits, the other is unchanged. Mutualistic, both partners benefit. Pathogenic, of course, is one partner benefits and the other one is harmed. And therapeutic, we'll talk about when we talk about interventions. Certainly, changes in the microbiome in the GI tract can contribute to several long-lasting chronic diseases. So the functions of the intestinal microbiome are really numerous. Certainly the normal bacteria, the normal microflora, competes with pathogens for nutrients and space. So really competes away pathogens. They can stimulate production of mucus. They can stimulate production of vitamins such as vitamin K and some of the vitamin B complex. It can activate those epithelial cells and is importantly can prime and regulate the immune system in the GI tract. Now, these gut microbiomes sense their environment and can monitor the density in the GI tract. And as we look in the next slide at each of these sections of the GI tract and the kind of microbes that are there, certainly we have to appreciate the different roles within the GI tract: digestive, immunologic, metabolic, and endocrinologic. So the GI tract, as I mentioned, really starts from the mouth all the way to the anus. But we're going to start our discussion really at the small intestine. So to orient you a little bit, here's the liver, and here in green is the stomach. The pancreas is here, and we begin the small intestine with our duodenum, and this gives you a little idea of some of the functions of the duodenum in terms of what it makes. We then have the jejunum, which can accentuate calcium absorption and make some of our vitamins. The ileum can also release bile acids into the digestive tract, and finally the colon. So as you can see here, as we go from the small intestine down to the large, the pH increases, oxygen tension or oxygen concentration decreases. You'll see here a really huge increase in the number of bacteria as well as their diversity. So again, looking at the different architecture of the small and large intestine can certainly remind us of what the function is. So within the small intestine, the function is primarily digestion and absorption of some nutrients back into the body. The transit time, the time it takes for food to pass through the small intestine, is only a matter of hours. Probably one of the reasons why there's a lower diversity and a lower density of microbes in the small intestine. In contrast, the colon or large intestine has no digestive secretions. Its job is really to absorb water and nutrients from the bowel movement. And consequently, it has a longer transit time, upwards to a day perhaps. And because of that, there's a much higher diversity and density of microbes within the colon. So in looking at some of the microflora, some of the bacteria that reside in the GI tract, there are just thousands of species. Unfortunately, we're not going to go through each of those tonight. But what I do want to just highlight, and I'll continue to remind you as we talk about these different phyla, there's basically 4 phyla: Firmicutes, Bacteroides, Actinobacter, and Proteobacter. And within Firmicutes and Bacteroides, these are more or less our good bacteria. In fact, within the Firmicutes, one of our prime probiotics is Lactobacillus. Within Bacteroides, again, there are several genus and species of good bacteria. That's in contrast to Proteobacters, which tend to have the pathogens. And finally, Actinobacter also has a very key probiotic known as Bifidobacterium. Now, many scientists and investigators have tried to look at the ratio of the Firmicutes to the Bacteroides in the GI tract, and they're suggesting that the lower the ratio, that is, the fewer Firmicutes and the more Bacteroides, that might signal greater GI tract health. So it might be used as a predictor of gut health, but this really hasn't been formalized. The ratio, and we'll see in a bit, the ratio of the Firmicutes to Bacteroides might also be a biomarker of obesity. But again, the studies just hasn't nailed that down yet. Now you'll see one aspect here, and I've highlighted this in Ötzi, right by Prevotella. So Ötzi is the Iceman. As you recall, he was discovered about 30 years ago by some German hikers in the Swiss Alps. He's a perfectly preserved frozen man from about 5,000 years ago. And they have been able to study Ötzi both in terms of his health. He had some diseases that we see in modern times, such as Lyme disease and arthritis. They've studied the clothes he wore and his weapons. They've evaluated the contents of his stomach. And they've also recently looked at the microflora in his GI tract. This was actually published last fall in a issue of National Geographic. So what they found is that he had Prevotella bacteria, and this would signal he had a very fiber-rich diet. So he probably ate a lot of grains and wheats and things like that. He also had Helicobacter pylori, a bacterium that has been associated with stomach cancer, and he had a pathogenic strain of a Clostridium. So it certainly is interesting to explore the microflora, not only today as predictors of disease, but also in individuals 5,000 years ago. So now we've kind of separated out the immune response and the microflora. Let's look at their communication and coexistence. One of the first things to describe is the effect of diet. So as you can see here, here is our GI tract. Here is our lumen in the middle. Dietary fiber is introduced to the GI tract, and the good bacteria, the normal microflora, breaks that down into what's known as short chain fatty acids. You're going to see this abbreviation a lot, CSFA. And I'll try and refresh you. Very important to remember, short chain fatty acid has a huge role in a healthy GI tract and frankly, other organs as well. As you can see here, it can help decrease obesity. It can reduce the level of fat in the bloodstream, can reduce plaque and atherosclerosis, and it can actually improve heart function. So these short chain fatty acids are key in maintaining gut health, decreasing inflammation, and decreasing immune diseases. How does this work? How is it that this metabolite of this normal good bacteria can affect so many aspects? Well, we start here in this side, and the left side is a picture of the GI tract in health. This is known as symbiosis. And you can see here all the great diversity of bacteria in the lumen. The light blue represents the mucus. And here's our epithelial cells that line the GI tract. And they actually come together in very tight junctions to try and prevent the movement of any bacteria to these underlying tissues. So short chain fatty acids, one of its main functions is to improve or increase these tight junctions, to improve that barrier. Short chain fatty acids can also activate goblet cells to improve increased mucus. And finally, it can improve those antimicrobial proteins. As importantly, short chain fatty acids can affect the immune cells in the underlying tissue and really increase the function of T regulatory cells as an anti-inflammatory cell type. We move over to the right-hand side. Now, this is the state of disease. So the GI tract, there hasn't been a good diet, good fiber-rich diet. Perhaps the host has received antibiotics or some kind of environmental stressor. This is known as dysbiosis. And you can certainly see here the diversity has gone way down, as has the number. And because we've lost many of our good bacteria, we've lost that short chain fatty acid. So goblet cells no longer make enough mucin. You can kind of see here in the decrease in the light blue. Our short chain fatty acid is not maintaining those tight junctions. So it's possible to have a leaky epithelial barrier. And as importantly, the effect on the underlying immune cells is to promote Th1 cells, T helper 1s as pro-inflammatory, and T helper 17s, again, as pro-inflammatory. Now, you might be thinking, well, that's good. We want that pro-inflammation to get rid of any pathogens or unwanted bacteria. Very true. But some of this pro-inflammatory cells can also damage normal host tissue. So how is it that this one molecule, these short chain fatty acids, can be so important in promoting mucus and antimicrobial proteins and the maintenance of these good bacteria. It really has to do with how microbes metabolize oxygen. So what we see on the left-hand side is health, symbiosis, and we see a diverse level of microbiome in the lumen of our healthy GI tract. Now, these tend to be bacteria that are obligate facultative anaerobes. This simply means the bacteria prefers to grow in low or no oxygen. And when that happens, it can form a very nice cycle of balance or homeostasis. It can metabolize oxygen via beta oxidation, improving and increasing short chain fatty acid that further increases the good bacteria, the diverse bacteria. So this is a great cycle of maintaining, as you can see here, the diverse large number of good or normal microbes. It can also improve mucus, antimicrobial proteins, and that antibody IgA. Enter the pathogens such as Salmonella, Clostridium, Vibrio, and now we get disease or dysbiosis. And in this case, we have a decline in those bacteria that prefer low or no oxygen. In this case, they tend to thrive in higher oxygen. Now we get a cycle of dysbiosis, and we have pathogens that increase in virulence, can be transmitted from host to host. And you can see here that we've got a lot more pathogens here. We've lost mucus. Our barrier has become leaky, and there is a decline in antimicrobial proteins and the IgA. So again, it's a matter of a cycle of dysbiosis, maintaining pathogenics which prefer higher oxygen, as opposed to a cycle of balance, which maintains good or normal microbiomes in an atmosphere of low or no oxygen. Putting another layer onto this, and that's looking at diet. So we'll begin first in our state of health or symbiosis. This is in a state of a high fiber diet. As you can see here, we're getting a high level of short chain fatty acids. And here's the abbreviation down there at the bottom. We also have an increase in vitamin A and D, and a balance between omega-6 fatty acids, which are kind of the bad ones, and omega-3 fatty acids. So we start here with a good diet. We have great integrity of that epithelial or mucosal barrier. We have homeostasis. We have good anti-inflammatory mucosal immunity, so a preponderance of those T regulatory cells. And this just continues to maintain those commensal or good microbiomes. We move here to dysbiosis, and here we're moving to a high saturated fatty acids, as you can see down here, high sugar, high saturated fatty acid diet. And because of that, there's a loss in fiber, a loss in those short chain fatty acid. We also have a loss of iron and far more omega-6 fatty acids than omega-3. So now because of this diet, our mucosal barrier no longer has the integrity we need. There is pathology within the GI tract. The mucosal immune system has lost its control. There's far more Th1s, Th17s, and inflammation than the T regulatory cells. And this cycle of dysbiosis will just continue until something changes, such as our diet, where we no longer are taking antibiotics, those kind of environmental features. So diet impacts the microbes, which impacts our immune system in the GI tract, which can affect diseases both in the GI tract and outside. And these diseases we'll discuss are known as autoimmune diseases. Now, autoimmune disease is when we have an immune response against our own healthy cells, tissue, and constituents. And they named this very accurately. An autoimmune disease is immunity against self. There's basically two different mechanisms that can underlie how the GI tract affects autoimmune disease. And there's really a lot of overlap between the two, but we'll separate them for a bit. One is that change in mucosal or cell permeability, that barrier defect. Another is the imbalance between our pro-inflammatory cells and our anti-inflammatory cells. So let's look first at what we call the leaky gut syndrome. And you're now all experts at symbiosis or health. Here we've got nice tight junctions represented by these horizontal blue bars between our enterocytes. Lots of good mucus in blue. We've got IgA in the middle, antimicrobial proteins, and good normal gut microflora. Now, in the face of environmental factors or genetic factors, so perhaps diet, low fiber diet, a vitamin D deficiency, a diet high in saturated fats and sugar, perhaps even in the face of stress and anxiety and depression, we then move into what's known as dysbiosis or disease. And you'll see right away the loss of mucus. We've lost our barrier function here, and we're starting to get pathogens, as you can see by the little purple microbes with the tails. We've also lost our regulation. So in symbiosis, this yellow cell represents a T regulatory cell. We've lost that cell, and now we have a pro-inflammatory cell designated by red. And finally, the absolute worst state is this leaky gut syndrome. As you can tell, we've really got lots of inflammation going on with these red lymphocytes. Lots of pathogens are breaching that barrier and going into the underlying tissue. And again, some of this pro-inflammatory response and the loss of anti-inflammatory response can lead to autoimmunity. The second mechanism, again, with some overlap, is this imbalance between our pro-inflammatory and anti-inflammatory. And this just talks to us about a change in diet, bad diet, perhaps infections with pathogens, antibiotics, can certainly cause inflammation or dysbiosis, as we see on the right side, where we're getting a lot more Th17s and Th1s as compared to symbiosis, where we have a lot more T regulatory cells that can block that autoimmune response. So we kind of understand the mechanisms by which GI tract immunity can lead to autoimmune disease. And these can be autoimmune diseases that are in the GI tract. We certainly know what a healthy GI tract can do. However, in a state of inflammatory bowel disease, and there are actually two kinds of IBDs, ulcerative colitis, which occurs in the large intestine or colon, and Crohn's disease, which occurs in the latter part of the small intestine and the large intestine. And patients can suffer from pain, diarrhea, weight loss, obviously episodic inflammation. So this can be due to environmental factors, as we've discussed, and even host factors or genetic susceptibility, again causing that disease or dysbiosis of the gut microbiome, an altered immune response, and eventually inflammatory bowel disease. So again, in symbiosis, we've got normal microflora, we've got rising good levels of short chain fatty acids and good levels of T regulatory cells. In the face of dysbiosis, we've lost that diversity, we've lost short chain fatty acids, and it's more of a pro-inflammatory response. The other thing I wanted to point out to you in this slide is that by losing those normal good bacteria, we've lost Firmicutes, Bacteroidetes, and one of those key probiotics, lactobacilli.
Andrea,
Yes.
we have a question
Oh, please.
in the chat. So the question is, so we increase both probiotic and prebiotic, prebiotics such as high fiber such as psyllium, and probiotic miso soup, question mark. I'm assuming that's something that you understand.
That's exactly right. And we're going, and that's a great question. We're going to cover both prebiotics and probiotics when we get to intervention, and we'll spell it out in a little more detail. But certainly, if you've got any more questions after that discussion, please go right on the chat or let me know after. So, but yeah, great question, and thank you for that. So we're looking now at, we talked about how changes in the gut immune response as a result of diet and changes in the microbiome can affect intestinal autoimmune diseases. It can also affect autoimmune diseases outside of the GI tract. Diseases such as systemic lupus erythematosus, which tends to appear in young women. Diseases of the skin, such as psoriasis. Thyroid glands, such as Graves' disease. Multiple sclerosis, central nervous system, autoimmune disease, and even cognitive disorders. What we're going to focus on tonight is two diseases: type 1 diabetes, which is a true autoimmune disease, and type 2 diabetes, which is a more disease of the older individuals with metabolic syndrome. So as we look first at type 1, and this is often known as juvenile diabetes or insulin-dependent diabetes mellitus, IDDM. This is an organ-specific autoimmune disease that tends to strike young people between the ages of 10 and 14, and tends to affect more young men than young women. And the end result is actually destruction of a cell in the pancreas. And that cell is known as a beta cell. That beta cell in the pancreas makes insulin. With the loss of insulin, there's no control as to how much sugar or glucose stays in the circulation. But we certainly can look back to changes in the gut microbiome that can affect the process or pathology of type 1 diabetes. And we look at these as risk factors. So they can be things like how much antibiotics are used that could affect the gut microbiome. Certainly, immune response genes can affect this disease, as can drugs, a low fiber diet, even pH of drinking water. I also wanted to point out delivery mode. So there has been some really good research on the impact of how a child is born, whether that child is born vaginally or by C-section. And being born by C-section actually is a risk factor for that child to one day develop type 1 diabetes. We also can look at the type of milk that the newborn can receive, whether it's breast milk versus formula milk. And again, formula milk can be a risk factor for the development of some of these autoimmune diseases. Now, I always have to put a caveat in here. These are not guaranteed factors. You may have, or a child may be born with all of these elements and never develop type 1 diabetes. These are just risk factors that scientists and clinicians have designated. Nevertheless, they can cause changes in the gut microbiome, losing that barrier function, decreasing our microbiome diversity, especially those short chain fatty acid producing bacteria, the good bacteria, and increasing pathogens such as Proteobacter. Because we have a loss in short chain fatty acid, there's a decrease in microvilli, tight junction, and those good probiotics, lactobacillus and bifido. And with those changes in the gut microbiome, there can be destruction of islet cells. For example, some of those cytotoxic T lymphocytes and other immune cells can attack. They recognize these beta cells as foreign. That's that true definition of autoimmune response. And they kill those beta cells with that loss of insulin. I noticed that there's a couple chats and Q&As up there.
There is. I was waiting for the perfect time to pop
Okay,
in.
I'm going to
It's actually, they're both from Gail. She accidentally hit enter. So she had commented, I think of mucus as bad, but you speak of it as a normal substance.
Absolutely. And I guess you think of mucus maybe in your nose when you have a cold, but it really is perfect. If you think about the nose and the respiratory system, mucus is great for catching things you inhale and getting rid of them, whether it's sneezing or coughing or even swallowing mucus. So mucus is a very key part of that innate response. Mucus is also important in the GI tract. It can help move those microbes down from the small intestine into large, potentially help move some of the nutrients through the small intestine down to the large as well. So great question. And oftentimes when
we do have one other question.
Please go right ahead.
Comments as well. Yes. And this had to do with when you were talking about the possibilities of type 1 diabetes for infants delivered via C-section.
Yes.
So the question was clarifying, is it the flora through the vaginal canal that makes the difference?
That is exactly right. So the lactobacillus predominates in the vaginal canal, whereas staphylococcus predominates in the skin of the mom. So that's the difference between what initially populates the newborn's GI tract or microbiome. But that's exactly right. Good. So we talked about type 1 diabetes. We talked about those risk factors tends to affect young people. And we talked about some of the pathology and the pathogenesis. We're looking now at type 2 diabetes, which affects adults. And the obesity often accounts for the vast majority of type 2 diabetes. Again, this is often known as metabolic syndrome. Some of the risk factors for type 2 has to do with choices in human lifestyle, such as how much physical activity, high calorie foods, such as high saturated fats and high sugar, even sleep-wake cycles. So as we look here at a healthy individual and their cells in their pancreas that make insulin are normal size, as that individual is not as active, eats too much, they may be metabolically healthy, but they are overweight. And you can see here that those cells start to enlarge and they actually increase the amount of insulin they produce. And one of the reasons for that is, although there's a lot of glucose or sugar in the bloodstream, the body for some reason is not able to move it into cells and tissue. And the pancreas senses that and begins to pour out more insulin. And this is what we call impaired glucose tolerance. We actually get that pancreatic dysfunction. And in a state of obesity, we actually can get destruction of those cells in the pancreas. So we have cell failure and true type 2 diabetes. So what happens with the microflora in this type 2 diabetes? Well, we look here first at always looking at health first. And this would be in an individual who had a great diet, one of those Mediterranean diets where there's lots of good, healthy fiber, grains, good, healthy fish, vegetables and vegetables and fruits. We see a good population of normal microflora, good barrier function, and lots of short chain fatty acid. In contrast are individuals who eat those Western diets. Again, high saturated fats, high sugar, and this creates a state of dysbiosis. The bacteria that are generated from that Western diet, which are not the short chain fatty acid producing bacteria, there are some metabolites that can affect the brain and the heart, the liver, and the GI tract. So you'll see here, there's a definite decrease in our good probiotics, the bifido and the lacto, and consequently a decrease in those short chain fatty acid. So certainly this metabolic syndrome can affect GI dysbiosis and vice versa. Now, one of the things that puzzled investigators is that they saw that there was in these individuals, when they evaluated their GI tract, they saw an increase in firmicutes and bacteroides. And they thought, well, what is going on? Because both of these produce short chain fatty acids. As it turns out, the firmicutes produce a type of short chain fatty acid, butyrate, which can actually cause fat production in the liver and accumulation of fat in host cells. And this promotes a more efficient absorption of calories. So going back to our friend Ötzi, the frozen mummy, this was really good for him because he didn't know where his next meal was going to come from. So storing those calories as fat gave him extra energy. In our world of loss of activity and bad diets, certainly having this type of short chain fatty acid is contributing toward obesity. And the last part of our lecture is going to talk about interventions. And as per the question before, we are going to talk about probiotics, prebiotics, and something known as symbiotics. We'll talk about changes in diet, and finally, something known as fecal microbiota transplantation. So prebiotics are really the food for bacteria. So these are the things that we eat that have high fiber. Probiotics are those live bacteria that we can get from active bacterial cultures. And symbiotics are actually foods that have both. So as a reminder, we ingest prebiotics or fiber. They are fermented in the GI tract by probiotics or bacteria into those all-important short-chain fatty acids. And you can see here all the different prebiotics and what they potentially do, such as improving immunity, promoting growth of the beneficial gut microbe, we've talked about that, improving calcium absorption, and producing those beneficial metabolites. Now, there's two kinds of prebiotics. There's soluble, which dissolve in water, and insoluble, which do not. Some of the soluble fiber can come from oats and peas and beans and apples, and insoluble can be in things like wheat bran or wheat flour. Now, the very best place to get your prebiotics are from food. If, however, your diet is not what it should be, of course, you can always go to the kind of prebiotics you can buy in the drugstore. Now, I combine that with our discussion of probiotics here, and because the designation of what they were was a little blurry, I typed them out here. What I wanted to especially emphasize are the two probiotics, bifidobacterium and lactobacillus. And so probiotics then should have, they're living organisms, they should have a number of viable cells of 40 to 50 billion per dose of probiotic that you would buy in the drugstore. There are usually several kinds of microorganisms, again, with the emphasis on lactobacillus and bifido. Now, you can also get these probiotics from naturally fermented foods, such as yogurt, kefir, which is fermented milk, kimchi, fermented vegetable, or as supplements. In choosing a probiotic, in choosing a bacteria you can buy in the drugstore, you want to look for something that is shelf stable. It does not need to be refrigerated. You want to look for something that has about 5 billion microbes per dose, that there's a great diversity in the strain. Again, emphasis on lactobacillus and bifidobacterium, that they're in a capsule that will survive stomach acid. And finally, that there is added some prebiotic or some fiber to that probiotic capsule. So this is one that I, of course, just took off the internet, but this gives us an idea of a very good probiotic where there are 18 strains, 51 billion. And the primary ones are Lactobacillus acidophilus and the bifidobacterium. And you also can see that they added some prebiotic fiber to that as well. So this would certainly represent what you would want to buy as best for your money in the drugstore. And as I mentioned, symbiotics are a combination of both, getting those in sauerkraut, kimchi, yogurt, or kefir. So those are supplements we can add to our diet. How about our diet itself?
And a quick
And we-
question from the comments.
Please.
And Tiffany, I apologize. I missed when you actually typed this in. You had asked miso soup has the most, and I'm not sure what most you were referring to.
Okay, probably has the most probiotics in it. I didn't know that. Is that right?
It was a question, and then it's followed up with but raw miso. So I'm not sure if it was a question of if it had the most probiotics, or if it's raw miso. I'm not sure if you're able to answer that, Andrea.
You know, I'm not. That's a great. I did not know that. That is great, and I'll certainly look it up and see what I can find. But thank you very much for that. So as we look at our diet and the gut microbiome, and we've kind of talked about this, the gut microbiome can respond fairly rapidly to dietary changes, such as increasing our fiber. The overall level of microbiota, however, remains relatively stable during adulthood. And it's only when we become in our 60s, 70s, 80s that the number and diversity of gut microbiome actually falls. If you want to impact a child's microbiome, the best time to do it is in the first 3 years of life. And again, we talked about the fact that the difference between vaginal and C-section, and between breast milk and formula milk. And obviously, some moms don't have the ability to choose between C-section and vaginal, but there's other things you can do to perhaps offset that, such as breast milk or good fiber in a child's diet. So the next 3 slides, I think, do a pretty good job of kind of comparing in a very visual way the effective diet. So if we see here plant protein, so let's think of our vegetarian friends, and they have a good level of those bifido and lacto, increase in the short chain fatty acid, great increase in Tregs, good integrity in the gut barrier, and blocking any cardiovascular or GI tract diseases, as opposed to folks like me who are carnivores and like our animal proteins. You'll see we get a decrease in bifido, a decrease in those short chain fatty acids, affecting cardiovascular disease, CVD, as well as driving inflammatory bowel disease as well. So certainly the vegetarian diet has a greater impact on a healthy GI tract. In looking at different fats, dietary fats, we look at unsaturated fats. So these can certainly be things like olive oil and peanut oil, avocado oil, as opposed to saturated fats like coconut oil, which is so good on movie theater popcorn, and butter, and of course meats as well. So with our unsaturated fat diet, again, nice increase in the probiotics. We do not get the accumulation of fat in white adipose tissue, and we block some of the effects on total cholesterol, as opposed to saturated fat diet, where we can potentially affect insulin and glucose level. There's a higher level of fat accumulation and a adverse effect on cholesterol. And finally, comparing 3 popular diets. So we look first at our Western diet. So this is having a burger and fries for lunch, followed by a pizza for dinner or for dessert. And obviously you're going to see a very strong decrease in good bacteria. So we've lost that fiber in the diet. And this is going to contribute to cardiovascular disease, inflammation, obesity, type 2 diabetes. Comparing that to the good Mediterranean diet of good fish, vegetables and fruit, whole grains, nice increase in probiotics, and blocking many of these deleterious outcomes. Now, the question about gluten-free diet, and this has not been nailed down. Clearly, this is not necessarily a fat-free diet. And so assuming here that the individual is eliminating gluten from their diet, but may not necessarily be eliminating saturated fats, again, we see that loss in probiotics, uncertain as to what the outcome might be. And we get to our third type of intervention. Is there, I'm seeing the chat lighting up a bit. Before I move on, is there other questions I can answer, Megan?
Nope, it was just a follow-up to the miso question. It was a statement that raw miso has the most probiotics.
Probiotics, good to know. So this is our last intervention, fecal microbiota transplantation. And this is exactly what it sounds like, the transfer of feces from a healthy donor to a diseased recipient. This is an FDA-approved treatment for patients with recurrent Clostridium difficile infection, which is often a complication of those inflammatory bowel diseases, those autoimmune disease. And the transfer of fecal material is usually by colonoscopy. These patients with RCDI often have a decrease in the fecal firmicutes and Bacteroides, so they have a decrease in those short chain fatty acids. But once they receive that FMT, it's about a 90% cure rate for this RCDI. And obviously the microbes in the recipient are going to mirror the donor. They have used this, although it's not FDA approved. They have seen clinical improvement in IBD as well as some forms of colitis. Now, as you can imagine, one of the hard things to do is to standardize this transplant of fecal material. So the pharmaceutical companies have come up with another option that's actually in phase 3 trials. And this is a pill that comes from or is made from human feces. And there was a great article about this particular trial a couple months ago in Science magazine, where they took stool or feces from pre-screened donors. So these would be individuals who may be vegetarian or certainly on a high plant diet, low fat, so they've got lots of good bacteria. They treat the stool with ethanol to kill any virus or fungi and any bacteria that are currently dividing. So left behind are bacteria that are in thick-walled structures called spores. And that's what we see over here in the blue. These are spores of firmicutes, which are good short-chain fatty acid producing bacteria. The patients in the trials took this oral pill 3 days in a row. And the pill was in a form that it could bypass or resist the stomach acid. So they made it to the small intestine and the large intestine. And so the bacteria were able to compete away the Clostridium difficile. And they also changed something called bile acids, which made the environment in the large intestine less hospitable. So this looks like it may be replacing that FMT, but we'll see as it goes through its phase 3 trials. So in our conclusions, I hope you can appreciate this really exquisite crosstalk between the bacteria in our GI tract and the immune system in the GI tract, and the impact that diet has on the microbiome, has on the GI tract immune response, either increasing or decreasing risk for disease. We talked about how those diseases could be autoimmune diseases and the mechanisms, as well as metabolic syndrome, which is not necessarily an autoimmune disease, but certainly can be caused by that imbalance in the microbiome. And of course, we talked about 3 strategies and interventions. So my takeaway or my walkaway message is always seek homeostasis or balance. Hippocrates said, let food be your medicine and medicine be your food, emphasizing the importance of making good choices in nutrition to provide longevity as well as the health of the individual. And I've got finished right at 7 o'clock. So thank you all so much for your attention. And I am more than happy to answer any questions you might have. I'll open up the chat so I can see it as well.
Wow, you really timed this out perfectly.
Well, I'm also kind of a fast talker, so. Okay. So do you see questions that I can answer?
I
Megan?
don't. It looks like we are all set. And I will make sure that I include your contact information in the follow-up email that goes out to everybody with the recording of this. And Andrea, thank you so much for your time. This has been fabulous. I was really worried when I saw some of those pictures, like, oh, this is going to go over my head. But you are very good at explaining these things.
Well, thank you so much. I've had decades of it, but you know, I also consider this such an important part of moving forward, whether you're young, middle-aged, or retired, you know, on the choices that you can make in your diet and in your lifestyle. So I really enjoyed doing that, doing this presentation, Megan, and thank you so much.
Of course. And Tiffany, I see that you have your hand up. I have allowed you to talk if you wanted to unmute if you had a question.
Hi, I was just wondering what your suggestions were for the prebiotic, because I had said like the psyllium. Do you have any other suggestions for like the prebiotic? I know I mentioned like the probiotic for a health like purpose, or natural purpose, like the miso soup. But do you have any favorites that you choose?
You know, I go for a lot of fruits, red grapes and apples. In talking to my gastroenterologist, he suggested benefiber, or not benefiber, Metamucil every day, if I was uncertain about how much fiber I'm getting in my daily diet. So it's kind of a personal choice. And you know, so much of this depends upon one's age and gender and lifestyle choices. And if you've got the lifestyle when you can really incorporate good fiber from your food into your meals, go for that. If you're like me and you're kind of sketchy or uneven about incorporating fiber, then certainly the Metamucil or benefiber can work just as well.
That's what I was saying, like the psyllium. Like I feel like psyllium's a really good choice for most
and
people
that's in Metamucil.
Because it's like a pretty like easy thing for people to take, and then it increases your hydration as well.
Exactly. And you can actually, if you take the benefiber or Metamucil, it fills you up so you're not that hungry. You can lose a little weight. I'm not making that or suggesting that as a weight loss treatment, but you know, I guess that could work.
No, that's definitely good for like people with diabetes and stuff.
Yes, exactly. Good. Great questions, Tiffany. Thank you.
All right. And thank you, Angel, for the comment. We definitely will. I will be chatting with Andrea to see if we can put something like this together again. Maybe we'll make a class out of it if we're able to make the logistics work. So, Andrea, do you have anything else you want to say before we log off tonight?
No, I don't. Again, you saw my my email address, and in the recording it'll be there as well. So please reach out if there's anything you'd like to talk about or ask a question. Thank you so much.
Thank you. Everybody have a wonderful evening, and we will be in touch with the next fun thing. Enjoy your weekend, and we'll talk to y'all soon. Bye.
Good night.
Thank you so much. I really appreciate you.
Great.